All right, good afternoon, everyone. We apologize for the delay, but we'll go ahead and get started with today's town hall. My name is Deanna Fenton, Program Manager here at the Alliance, and it's my pleasure to welcome you to today's program, which will focus on the hot topic of cardiac transplantation using DCD donors. Before we begin, I'd like to briefly review some important information regarding today's program, as well as a few of our future town halls. First and foremost, you may have noticed that your audio lines have all been muted. Your lines will remain muted for the duration of the town hall presentation. That said, all questions or comments will need to be submitted electronically using the Zoom chat feature. For those of you who submitted questions during the registration process, please know that we've done our best to compile your questions and we'll address as many of them as we can. Should you have any additional questions, please feel free to submit them once again using that Zoom chat feature. Following the conclusion of today's town hall, you will receive an email from us with outlined instructions on how to access our post-town hall evaluation. Now, while continuing education credits are not offered for this program, you will have the opportunity to claim a certificate of completion as a result of your participation. We highly recommend that you complete these evaluations, as your feedback is invaluable to us and will help us to develop future programs. If you have any questions or issues, please don't hesitate to contact a member from the Alliance team. Now, as an added note, we will be recording today's presentation. So if you or a colleague is interested in viewing today's town hall at a later date, you can access that recording on our website at organdonationalliance.org. There, you'll also find information about our upcoming programs. That said, I'm happy to announce that we've just opened registration for our next town hall, which will focus on the current pandemic and how it's impacted the pediatric patient population with respect to donation and transplantation. We welcome you to join us for that on September 17th at 2 p.m. Eastern. Now, without further ado, I'd like to kick off today's town hall by introducing our moderator, Dominic Adorno, Vice President of Clinical Operations at Life Center Northwest. Dominic, it's a pleasure to have you with us today. And at this point, I'll go ahead and turn it over to you to facilitate today's discussion.
Thanks, Deanna. So yeah, we're happy to have Dr. D'Alessandro from Mass General to be talking about his experience with DCD Heart transplant, and then we'll have some questions that you guys had submitted during registration, and then we'll follow through with any live Q&A if we have some time. So we have the ability to go over a little bit if we need to. So without further ado, please welcome Dr. D'Alessandro.
Thank you, Dominic, and thank you for the meeting organizers for the opportunity to present on this exciting topic of DCD heart transplantation. The title of this very brief presentation is "What is Old is New Again," and hopefully that'll make sense in just a few moments. Could I have the first slide, please? So in 2015, Camus, Dital, and Peter McDonald's group published this landmark paper describing their experience in 3 patients that successfully underwent heart transplantation with DCD donors. And this was really the first time in the modern era that this had been done in adult patients. I will draw your attention to the title where they describe DCD as donor hearts after circulatory death. Before that, many people often referred to this as donation after cardiac death, but they reminded us that these hearts are not dead and that they're in fact very much alive. Next slide, please. Some of you may remember, but many people have forgotten that the very first human heart transplants were done using DCD hearts, because in the late 60s, there were no legal definitions for brain death. So in order to be a donor, a patient had to die from the loss of cardiac function. And that's how the very first transplants were done. If those donors were in close proximity to the recipient patient, you could quickly take it out and essentially resuscitate it in your recipient patient. And the hearts would generally work pretty well. But it was not very reproducible, and it limited our ability to travel distances, and it drastically reduced our access to donors. And so when brain death definitions were established in the early 70s, we very quickly moved to donation after brain death, which gave us the ability to protect the organs better and to travel distances to go get them. And that vastly improved our access to donor organs. Well, DCD hearts, as you know, have been successfully used in abdominal transplantation for many years now. And that's been used to expand the donor pool of kidneys and more recently livers. We now have successfully a growing experience transplanting lungs using DCD donors. And then there's been encouraging results in animal models using DCD hearts. And we now have an enlarging experience in Australia and in Europe using DCD donation and human transplantation, where it appears that the results with DCD heart transplantation is equivalent to that of brain dead donation. And as you probably know, we now have a US clinical trial that's been ongoing since the fall of last year. And I'll touch on that a little bit in a few moments. Next slide, please. Of course, the challenge with DCD cardiac donation is that the heart undergoes an obligatory hypoxic cardiac arrest. Then there's additional injury with the warm ischemic standoff period before we get access to the organs to protect it and procure it. And then when we reperfuse the organ, there can be additional injury with a reperfusion injury that can affect its early function. So when we're utilizing these DCD hearts, it's really important to have some ability to both resuscitate, but also to assess the donor heart before we put it into our patient. Next slide, please. And there's generally two ways of doing that. There's an in vivo or an intracorporeal approach, and there's an ex vivo or an extracorporeal approach, and both are being used for DCD heart transplantation clinically today. Next slide, please. The in vivo approach is sometimes referred to as warm regional perfusion, and this has become more popular in Europe. It essentially uses ECMO to both resuscitate the donor heart and also to evaluate the donor heart. In order to do that, you need to occlude the vessels to the brain to try to prevent cerebral reperfusion. And then the donor heart, as well as the other organs, are both resuscitated and evaluated in the patient. You can use a PA catheter to look at intracavitary pressures, cardiac output, and again, you can assess the heart in its loaded or working state. And this is sometimes facilitated with premortem femoral cannulation. An example of that is on the next slide. This is a group from Belgium that published this paper just a few months back. And what they do is they bring their donor patient to the operating room. They cannulate them under general anesthesia. Then the donors are withdrawn from support. And when they die, they're quickly opened, the head vessels are clamped off, and then ECMO can quickly be established. You can imagine that's a very effective way in having DCD donors progress, but I do not think this would be an acceptable technique in the US. Next slide. Advantages of this approach are that it's low cost, it's quick, and that I think the main advantage is that you get a full hemodynamic assessment of the heart in its working state. And another big advantage is that there's no FDA oversight with this technique. So essentially any center that wants to try this can do it without the FDA's, without needing FDA approval. Some disadvantages are that in order that once the heart has been assessed, it needs to be procured again. So that needs to be rearrested, which could incur an additional injury to the heart. And some have raised ethical concerns with reestablishing blood flow to the donor patient, even though we do our best to prevent cerebral perfusion. Next slide. The alternative approach, which is the way we've chosen to do it, is an ex vivo approach, and this uses warm machine perfusion. This ideally requires a collection of donor blood for the perfusion of the donor heart, and that organs are individually administered preservation solution and procured. And in order for this to be done successfully, it's really paramount that there's good communication and cooperation among the recovery teams. Next slide. This is the machine we're talking about. This is the Transmedics Organ Care System, or OCS machine. And this is what's been successfully utilized in Australia and now in this country to do DCD donation. Next slide, please. Here's a schematic of the way it works on the machine. Blood is administered to a cannula in the aorta. That perfuses the coronary arteries. The coronary artery blood is returned to the right side of the heart. The superior and inferior vena cavae are sewn closed, so all that blood is pumped from the right ventricle to a catheter in the pulmonary artery. This tubing then has a flow probe on it, which gives us a very accurate measurement of coronary blood flow, and that's returned to the system where it's oxygenated and recirculated. It's important to understand that the left side of the heart is open. The left atrium is entirely open. There's a vent placed across the pulmonary valve so that the left ventricle is essentially perfused but not working at all. The right ventricle is pumping about 800 to a liter of blood per minute, which is about 20% of its normal workload. So the right ventricle is only partially working. Next slide. With this system, we can control the heart rate because we have epicardial pacing wires on the heart, and we can control the aortic pressure and the coronary blood flow using adjustments of the pump flow and also the administration of adenosine, which is a potent coronary vasodilator. It's very important to understand that what we look at in evaluating the heart and what we use to assess it is not its ability to generate cardiac output. It's the heart's ability to utilize lactate as an energy source. In the normal condition, the heart uses lactate, it does not make lactate. And when the heart is making lactate, that's a sign of injury or pathology. And that's what we use as a surrogate of function, its ability to utilize lactate. Next slide. This is what the heart will look like very quickly after it's reperfused on the OCS system. It will start to beat, usually quite vigorously. In the DCD hearts, it tends to be more delayed in reestablishing a synchronized rhythm because the donor patients are pretty metabolically deranged. The donor patient has just died. They're often the blood is acidotic and hyperkalemic. So the elevated potassium in the perfusate often prevents the heart from beating right away. And it's important that we massage it and prevent it from being distended. As long as the heart's not distended, it's being reperfused and it's being protected and it's recovering. And at most, it might take 10 or 15 minutes before it'll start to beat again in a fairly normal fashion. Next slide, please. This is an example of some of the information we get on the hearts. The open circles here is the coronary blood flow, which tends to be somewhere between 800 and a liter per minute. These bar graphs are the lactate levels. And if you look all the way over to the right of the slide, you can see that the lactate levels are quite high. Again, the donor patient has just died, so not unexpectedly, the lactate in the donor blood is high. In this case, it's about 6.5. And we commonly see that while the heart has sustained an injury and is recovering, it does in fact make lactate often for the first hour or two. In every instance where we've put a DCD heart on the donor or on this system where the donor has met criteria, the lactates have eventually started to go down over time. And again, generally after about an hour or two, they'll level off and then go down over time. So this tells us that this heart is in good working order. And it's right about here where the lactates level off and then start to go down that we will start our recipient operation. Before that, we wait because we need to make sure that the heart can utilize lactate. Otherwise, that's a sign of perhaps irrecoverable injury. And that's a heart that we would not want to use. Next slide, please. So the big advantages of ex vivo perfusion, I think, are that it's less controversial, but importantly, it maintains the donor organ in a warm, perfused, and protected state. And this gives us the ability also to then travel long distances, which is quite advantageous when there are very few DCD organs being used, and they sometimes are being offered quite far away. The big disadvantages of this system, first of all, is cost. This is expensive machinery and expensive perfusion packs. It requires commercial technology, and this invites FDA oversight. And this has been the big delay in utilizing and doing DCD transplantation in this country, is that we had to wait for the FDA to allow this clinical trial to happen. And importantly, we cannot achieve full hemodynamic assessment of the heart, and you have to be a believer in lactate as a reasonable surrogate of cardiac function. Next slide. So we now have a prospective, randomized, and concurrent controlled trial to look at DCD transplantation in this country. What does that mean? It means that we're comparing DCD heart transplantation to standard of care heart transplantation using brain dead donors. It's a 3-to-1 randomization, which means patients are randomized, but they get a 75% chance of randomizing to the DCD possible arm and a 25% chance of being randomized to the standard of care arm. If they randomize to DCD possible arm, they get the first donor organ that's available. If that's a DCD heart, then that's what they get. If it's a brain dead donor, then that's what they get. If they standardize to standard of care, they can only have access to standard donors. We expected that this would give us approximately 50 DCD heart recipients to compare with 150 standard of care recipients. It turns out that the wait time for the DCD possible patients has been so short that we had to readjust that, and we now expect to have 90 DCD transplanted patients to compare to about 90 standard of care patients. And again, enrollment has been brisk and transplanting has been brisk, and we expect to complete enrollment just within a few months, in and around October of this year. Next slide. The inclusion criteria these are standard master category 3 donors, which are the usual donors that we use in transplantation. It's a rather conservative set of restrictions. The donor age must be below 50, and the warm ischemic time must be below 30 minutes, which I think is quite conservative. How do we define warm ischemic time? That's the time, the clock starts when the donor patient becomes either hypotensive, defined as systolic blood pressure less than 50, or hypoxic, defined as a peripheral oxygen saturation of less than 70. From that point in time to the time that we administer cold cardioplegia to the heart needs to be below 30 minutes for that to fit our inclusion criteria. And exclusion criteria are sort of obvious. These are the hearts need to have demonstrated normal function. They can't have known coronary disease or known significant valvular disease. We have transplanted 15 DCD hearts at our institution. It's expected that about a quarter of these patients will require ECMO. That's sort of the situation that they've seen in Europe. 3 of ours had required ECMO in the first few days. All of them have had return of normal function within a few days, and all patients have had normal function by the time of discharge. So we've had a very favorable experience so far with our 15 patients, and we are both excited and optimistic about the future of DCD transplantation in the US, and look forward to the conclusion of this clinical trial. I think that's the last slide. So I just want to thank you all for your attention, and I look forward to our discussion.
Thanks, Dr. D'Alessandro, for the background. It's really helpful. I think a lot of people are energized about this topic. I know we are out here in Seattle after doing our first one. So, for programs that are looking to start up the program or in the beginning stages, what advice or what can you share about the conversations that you're having with patients about the option of receiving a heart from a DCD donor?
Yeah, I can tell you that at our center we've used this machine for the EXPAND trial, so we had a fair amount of experience with the machine. It does take some convincing. It's that lactate is a reasonable surrogate for function. That's not intuitively obvious to surgeons anyway. I do believe, however, that that's true. So I was very comfortable using the machine. We had also done some preclinical work using human hearts, DCD hearts, and evaluating it on the machine. So we got some experience at our center utilizing these hearts, and I was convinced that this was going to work. It was a little bit difficult in the beginning, as you mentioned, to convince patients of that. And it sounds like we're trying to experiment with them on marginal donor hearts. And it definitely, the first few patients that we consented for this, it was a lengthy discussion. I can tell you that it's now out there in the community, so patients have read a lot of the lay press on this topic, which I think has been favorable. The patients seem to know more and more about it and are excited about it. And now that we have amassing good results at our center that I can talk to them about, it's become easier and easier to put them in the trial. And the advantage to them with respect to the waiting time is really quite impressive. So it's an obvious advantage to them to be in the trial.
That's great, thanks. And recognizing that there's a lot of resources that go into these recoveries, whether it's bringing the device with you, if that's requiring transport via charter aircraft. Can you talk about what, in the inherent risk of having a dry run, what goes into your decision making in terms of which opportunities that you're going to pursue?
Yeah. So as you mentioned, it is quite expensive. We try not to open equipment and so that we, don't incur that cost, but just the cost of a plane and sending a team to a donor heart is a significant amount of expense. So, in order to get these organs, you have to go and evaluate them. And that it's always difficult when you don't go and then find out that a donor did progress and you lost that organ, and that influences our decision-making. But we look at things like how much support is the donor patient on? Are they overbreathing the vent? Are they being sedated? Are they on pressors? Are they on high vent settings? Things that you would suggest that if you were to extubate them, that would be that patient would progress to death pretty quickly. So there are metrics out there that we utilize. I would not say our ability to predict is super good, but we'll be a little bit hesitant in going long distances for a young donor that's not on a lot of support. For example, I turned one down from across the country this morning because it didn't look like they were going to progress, and we've had a couple of negative runs. That it's hard on our team and it's hard on our patients.
Sure. So on the ones that you do go out on, I'm assuming there's some recovery logistics and challenges with the abdominal team and stuff like that. So you can talk about how you walk through and navigate those challenges?
Yeah, as I mentioned, coordination and cooperation is essential, and that starts with good communication. So the communication needs to start early, and it's primarily between the liver team and the heart team, because there's data that the liver allografts are very sensitive to every minute of ischemic time. And so their goal is to reperfuse that liver absolutely as quickly as possible. As I mentioned, we really need to take donor blood to use as our perfusate. That's what the preclinical data and the clinical data shows is best for our donor organs, and that takes a little bit of time to do that. And so in the best case scenario, it doesn't slow down the liver team at all. In the worst case scenario, it may delay them by a minute or two, which they really don't like, and understandably. So we do everything we can to prevent any sort of a delay on the liver team, and that means we really only send very experienced surgeons that have done this before. It's not fair to put them through that learning curve, and we have a standby system of washed donor blood that we bring along just in case we can't capture enough recipient blood to try to prevent slowing down the liver teams. But that is definitely out there in the community. That has been a sticky point between the liver surgeons and the heart procurement surgeons.
Sure, and you talked about using lactate as a surrogate, and I can tell you as an OPO, as soon as the heart left, we're very anxious to see if it's going to be used. So when you talked about that time period of kind of watching the lactate levels, when do you have a good idea that you'll be able to use the heart, and how long is it until you're making your final decision? Yeah,
so you get a pretty good idea within the first hour just by the visual assessment of the way the heart's working. I think that the criteria for inclusion into this trial, as I mentioned, are pretty conservative. A 30-minute warm ischemic period, I think, is pretty safe and reproducible. Could we go longer? I think we probably could, and at some point we'll trial, extending that boundary a little bit. But in general, when a donor is going to progress, they often do so within that period of time. So it doesn't seem to, we don't seem to lose a lot of donors because of that 30 minutes. As I mentioned, it takes about, somewhere between an hour to 2 hours before those lactates really level off and start to come down, but you'll start to see a signal of that happening beforehand. The venous lactate will start to drop with respect to the arterial lactate, and that tells us that the system lactate should start to go down. It sometimes lags a little bit longer before we see that actual drop, but it tells us that the heart is now utilizing lactate, and we know that's the sign we're waiting for. And we wait until we know that for sure before we start our recipient operation. But of the 15 hearts that we've put on the machine, we've been able to utilize all of them.
That's great. And I want to do a quick time check with the Alliance staff. I know we're at 11:30. Do we have some flexibility to go on a little bit more?
Yes, I would say we could take some time to address some of the additional questions.
Great. Thanks so much. So, realizing that the typical ischemic time is no longer there, using a warm preservation. Like, what is your tolerance for the heart outside the body, and kind of where do you see this technique being able to extend those times as we move forward beyond or to
Yeah.
greater distances?
Yeah. So, when you look in the trials of the OCS system and heart transplant, in general, the out of body time are somewhere between 5-6 hours. They're often, 4, 5, 6 hours on the machine. And we think that's safe. There's been reports of, excess of 12 hours on the machine. So we do think that, you can go fairly long periods of time on this system and probably safely, but as that time does add up, you do tend to see a little bit more edema of the donor allograft. And while that, and if you're limiting it to a reasonable length of time, doesn't seem to affect function of the heart, it may affect function if you were to extend that much beyond that. So we can comfortably go out from the East Coast to the West Coast, I think, and down to Puerto Rico and other places in the Caribbean. I do think it gives us the ability to travel, long distances. I don't think we're going to be sharing organs with Europe anytime soon with respect to hearts, but I do think this allows us to really move around the country so that we're best able to utilize these organs.
That's great. And along those lines, I think, some of the people asked about, like, where do you see the impact of DCD heart transplant, that process on increasing the number of hearts available? Is there a percentage, or what are your thoughts at the impact this will have?
Yeah, the estimates that others have offered and applied some science to is that somewhere between about 20 and 30% increase in donor hearts. And it does appear that that's a reasonable figure to shoot for. What I hope doesn't happen is I hope that brain dead organs don't start to erode into becoming DCD organs, and that we allow brain dead donors to declare themselves, because I do think brain dead donation for heart transplantation is certainly easiest and least expensive, probably for all the organs. But when they don't meet criteria and families want to proceed sooner, I think it's going to be a significant percentage of donor hearts for us.
You talked a little bit about outcomes and the 15, patients you've had, and they've done well, but I think it's important to highlight this is a non-inferior trial. So you're not looking to say that this is better than brain dead transplant. It's similar. So any unexpected lessons learned or results in the 15 patients that you guys, in your experience?
Yeah, really not. Again, we don't expect this to be better than. We do expect it to be as good as long-term. It was predicted that there'd be about 25% ECMO use, and that seems like that may be, that may actually be the case, that there's going to be a little bit more ECMO applied to these hearts. I can tell you that when they leave the operating room, even the one that I had that went on ECMO, they come out of there with vigorous, biventricular function, which is not always the case with hearts that are kept in cold storage that have longer ischemic times. They often limp a little bit. These hearts don't seem to limp as much up front. We have had a couple go back, and one of these went back more for bleeding problems, I think, than dysfunction problems. So I don't know that we're going to need to rely more on ECMO as we gain more experience, but I've been very impressed with the early function of these hearts. And I do, I think whatever injury these hearts suffer, they quickly resuscitate. And I think the warm machine perfusion is helpful in that respect.
I think when you and I had our initial conversation, when I first heard ECMO, I think that has a different connotation than somebody who's maybe going on dialysis for some delayed graft function. But is that analogous to kind of what's happening here?
Yeah, I like that. The kidney surgeons call it delayed graft function, which sounds really nice. We call ours, primary graft dysfunction, which sounds a lot, more punitive. I think we'll get to the point that we may call our hearts delayed graft function, and we'll put them on ECMO for a couple of days. And just as in the kidney literature, they've shown that long-term, that delayed graft function does not affect their results. I think that will likely be the case in our heart transplant population. I think where patients can suffer is when we don't recognize they're in a low output state and we allow them to remain in a low output, low perfused state. That's when we see a lot of complications. If we apply ECMO early and appropriately, I think we resuscitate both the organ and the patient and keep them safe. And I think that's the step forward here.
That's great. There's just some technical questions that were submitted, but, is there any difference in implanting a heart from a DCD donor versus a brain dead donor?
Really not. Generally it's the same technique. There can be times when there might be a shortage of aorta or pulmonary artery, especially if we're sharing with the lungs. And there are ways of having an interposition graft if you need to add length. But, in general, when a heart's coming in this manner, we save a little bit more cuff length on the recipient side so that we know to account for that. It's really the same operation. I can tell you that the rush to get, an LVAD and a heart out, for example, on the recipient side is not there when the organ's on a perfusion system. And that is, I think, hugely beneficial to not feel that rush, which can sometimes lead to surgical error. So I would say, if anything, it's more relaxed.
Great. And you and I were talking about kind of what's the next steps of this and how do we grow this? And we talked about the limitation of having these types of devices located in the right spots around the country. And then we talked about local recovery. So can you talk about how you think having a local recovery system could really expand the use of DCD hearts for transplant?
Yeah, I think there's a lot of exciting technologies coming out, particularly for heart preservation. And as we talk about moving away from cold storage and towards more sophisticated ways of protecting the heart, it does apply cost. And one of the ways of saving cost is to not fly procurement teams around the country, but to utilize local procurement teams. This has come up a lot in the COVID-19 pandemic, era, where we're trying to, first, it was not to save costs, but just the safety of moving procurement teams around the country in planes. And it was thought, well, we ought to utilize local teams and just send the organs and not the teams themselves. And that would probably be a safer way of doing it. And I do think it's not only safer, but it's cheaper. And a lot of small programs have these procurement teams that aren't necessarily super experienced. If you had a smaller number of very experienced procurement teams, I think it would both be cheaper, and I think results could potentially even be better. And I think it would be particularly applicable for something like this, where that level of experience is even more important. So yeah, I think the future will see local experienced teams that are perhaps organized by companies rather than OPOs, although I think OPOs are probably the right people to do it. I'm not sure whether they'll all have the foresight to doing it, and companies will step into that space perhaps. But I think that will be the future, and I think that will be a step forward.
And off chance, you happen to know how many OPOs you travel to, or how many programs are using this device currently?
The trial called for up to 15 participating centers with a DCD. There's a few other centers. I know NYU has been the major one that are using warm regional perfusion and exploring that technique of doing it. I don't think we're up to 15 centers enrolling in the trial yet, but we're probably up around 10. And I think that I think it's very likely if the results of the other centers that are participating in this trial are similar to ours, I think it's very likely this will get approved fairly quickly by the FDA. And then I think it'll diffuse out there into the other centers. I think it'll be adopted by the bigger centers more quickly than the smaller centers. And the smaller centers might even wait until we have that sort of, regional procurement teams like we just discussed, because they're going to be very sensitive to their numbers.
Yeah, I recall you saying you've traveled out as far as Wyoming. Can you talk about the different places that your program has gone out to for these recoveries?
Yeah, most of ours have come from the East Coast. We've had a few from, Florida, Tennessee. We've been out to Texas to look at organs. I'm not sure we got one successfully from them, but we've been around the country, Colorado, other places. So we definitely, you have the luxury of having the heart again in a perfused, protected state, and so we have the time to go out. The other thing is a lot of our patients now are status 6. They're lower down, And we, those patients are excited to get into the trial because really their only access to organs right now, if you're way down on the list like that, is if you're in the DCD trial. And we've had a few non-re-op, very smooth transplants come using these organs, which has been nice as a surgeon to be able to do those types of easy operations. It's nice for us and it's nice for the patients.
Sure. And any experience, I know I've seen reports that we've had a 7-organ DCD donor in the US, but for your program, have you gone on recoveries where you've done a DCD lung recovery and a DCD heart recovery?
Yeah, we've had some where we've split the organ, but the one that we recently went to, we had 2 teams from our center, one for the lungs, one for the heart, one surgeon, but it required 2 planes because the plane is not big enough for 2 of these OCS systems. So we needed a second plane in order to get both perfusion systems there. That adds a lot to the cost. But unfortunately that donor didn't progress. So that was a lot of, expense for, an unfavorable outcome. But we're willing to do that because we know that it's a little bit unpredictable, and that to be able to, get access to 2 organs that we wouldn't otherwise have, we're willing to take those gambles.
Sure. And we had a question come in asking if you're aware of any of the programs in the US that are using the in vivo technique.
Yeah, NYU has used it successfully. And I know there's a lot of discussion about, one of the disadvantages of the in vivo technique is that, if you send your own team out, they've got to go with a system. And then once the heart is procured, it's generally kept in the standard cold storage fashion, although you could use a Transmedics or some other system. It's generally put in cold storage. And so that sort of limits the distance you can go. So I don't think you could go out to the Midwest or the West Coast safely to do the in vivo ECMO approach. But NYU has been a proponent of doing it that way. And I know they're reaching out to other centers to try to get more people interested in it, because if you get a group of centers interested in the in vivo approach, then you have a network, and that allows the centers to do it for one another with local procuring teams, which again I think is the step forward for both techniques.
Okay. We had a question come in asking about the utilization of blood from a blood bank. So are you you use blood from a blood bank?
Yeah. So the science, most of the preclinical work was done by Peter McDonald and his group in Australia, and in their lab, when they used bank blood, the results were much less favorable. I don't know if the condition in animals or whatever research hearts they were using is necessarily the same, but the problem with donor blood is that it doesn't, the electrolytes are not balanced. There's a lot of citrate in it. The potassium can be quite high. The shelf life of those bank cells is variable. So what we've been doing is washing it with a cell salvage system. So we wash out the citrate, and we wash and we try to normalize some of the electrolytes, and we bring it along just in case. I do think you can utilize bank blood. You can certainly augment your perfusate with bank blood. It would be perhaps problematic to replace it entirely with bank blood, but I do think we can safely augment it. So I think it's a reasonable backup system, but it's not ideal. Ideal is donor blood.
Okay. We talked a little bit about just kind of the resources that go into it. And I think the questions are, we realize that these devices are not cheap, and kind of how does your program balance the cost of these procedures with the cost of just doing a heart transplant?
Yeah. What I'm told is, and I don't know this to be true, but I'm told that somewhere in the system of the finances of transplant that this does get reimbursed. The major cost of this device and using this equipment does get reimbursed. Does that happen every time? Probably not. And I think that probably it will somehow affect the profit loss statement of the transplant program. But even I think utilizing these devices, it's still financially favorable. And I think it would be nice if this equipment came down a little bit in cost, but I do know that the company has expended a lot of money in developing this technology. They have a lot of investors they're beholden to, and they're going to need to recoup that money somehow. So I really don't see the price of this coming down. And in fact, if it gets approved, I suspect at some points it's even gonna go up because people are gonna want it and they're probably gonna be willing to pay for it.
Okay, just a couple more questions that, people are asking about kind of the average length of stay post-transplant. So you and I talked about that when we were doing our
Yeah.
prep. But any difference there from a brain dead to DCD donor impacting the length of stay on your patients?
Yeah, I think it's been too early to tell. We've only done 15, but my off-the-cuff assessment is it seems to be no different. Even the patients that required ECMO for a couple of days bounced back quickly from that and went home within a couple of weeks. Our target is usually about 2 weeks, 10 days to 14 days. That's when we, like to send our patients home. And I'll say it doesn't appear to be any different than that. I don't think it's necessarily faster, but it doesn't seem to be any longer. I don't think it's any different.
Okay, I think that's all the questions that have come in through the chat box and the ones that I addressed earlier that came in that were submitted in advance during registration. So I just want to thank you for this. Again, this is a great topic. Thanks for the Alliance for putting this on. I want to thank the board and just everything that I think it's a very informative conversation. So thank you very much, Dr. D'Alessandro.
Thank you very, very much for having me. It's a great topic and I'm happy to come back and speak on it if you want to do this again in the future.
Yes, thank you. I want to echo Dominic's sentiments on behalf of the Alliance. We sincerely thank you both for your efforts in coordinating such a fantastic and insightful discussion. I think you can tell based off of the level of engagement and questions we've been receiving, this is definitely a hot topic. So I appreciate all the time and effort that you put into this. And of course, to all of our participants, we thank you for your participation and we hope you found this presentation very valuable and we look forward to seeing you in the future. So with that said, enjoy the rest of your day and stay safe, everyone.
Thank you.
Thank you.